And certainly, again, appreciate all the doctors giving up their time on a Saturday. It's still raining out, so you're not missing any sunshine. So, and also make sure that you stop by the support tables over here with the sponsors and the support groups that took time out of their day to join us today, too. They've got some great stuff to share with all of you.
Someone must have a question. Yep, over there. There's a question there.
Okay, so, that last presentation about T cells and the virus, wouldn't those T cells die after 2 or 3 weeks? And then how do they keep them, because don't they have to, T cells grow in the bone marrow?
They're engineered and they actually don't die. They've seen these cells in the peripheral blood of patients a year or so later. But again, the goal is to kill everything in sight. And if they kill everything in sight, you don't need them anymore. That's what happens when you get a virus infection. Your T cells well up, they kill the virus, and then they're gone. They may be memory T cells there that recognize that virus again. Or if you get a virus vaccine for influenza, the T cells are educated to kill the virus if it appears again.
So Pat, you might say the people that respond the best and do well for the longest are the ones where those T cells stay in their body.
Yeah, that's real preliminary. That's preliminary data, and because again the numbers aren't huge, but that may indeed be the case.
Hi, I want to direct this question to Linda Burns, and probably Dr. Rodriguez might be able to help with this one also. I'm a multiple myeloma patient. And I'd like to know if there's a test available concerning the transplant. I'm looking at my second one. If there's a test available to check to see if the bone marrow has burned out and that the stem cells won't regenerate after a transplant. Is there a test available? And after how many failed drugs do you feel that a second transplant is actually needed?
Do you want to go ahead and go first?
Yeah.
Or I can
Yeah. Well, I think that a bone marrow biopsy will bring some light into your question and about how safely it will be to go ahead with a second transplant. But I can tell you that one of the predictors for success is going to be how long it took for the disease to come back after the first transplant. As you can imagine, you don't have to be a doctor to know that, or to think that if someone had the myeloma 10 years later, probably is going to do better than if you had a transplant or you need a transplant 6 months after the first one. So that will be the first thing, and usually more than 12 months is kind of a good indicator. Less than 12 months, if you do a second stem cell, you probably need to follow by some other type of therapy. In regard to how well patients do, the studies have shown that mortality is not an issue from the transplant. I mean, thinking that someone is going to get harm on the second transplant is not the most common phenomenon happening. But certainly, I think that only the transplant will not be enough. That will be just a platform to continue with other therapies, trying to maintain the remission that they achieve with this second transplant.
Well, it's been 8 years since the last one.
So that is a very good prognosis. I mean, we all have patients in that situation because, unfortunately, I mean, multiple myeloma is still not curable. It's not curable yet, as I said. But I have a patient from 2002 until 2014, and that's when she had the myeloma coming back. She went for a second transplant, and still doing well and counting.
And I understand that transplant, of course, is the number one still best therapy for myeloma, but with all the new drugs that are available, is really a transplant still necessary?
Right, because they are not alternative, they're complement. So when you look into two groups of patients, if you treat a patient with just some of these new therapies or the other group is with the combination, usually the combination does better. Now, the remissions are going so deep that the tools that you have to detect disease, sometimes they don't see the myeloma. That's when we call for minimal residual disease, which are other technologies that are more sensitive. Even using those tools, when you look into patients after very effective therapies, many of them goes into this negative minimal residual disease. If you add stem cell on those patients, the number of patients who achieve that MRD negative is even larger. So as long as patients are in good performance, it is recommendable to enjoy all the options that are out there rather than trying to select one over the other, because at this point there's no winners. Combining them is what works better.
So I'll just add briefly to that. So you asked really good questions. I'll address the second one first. Is that today, as we said here on the stage, still the recommendation is to undergo an autologous transplant at the time of first therapy and the best outcome. There certainly have been studies that transplantation will work well later on in the course of disease as well, and some clinical trials are still ongoing with that. But autologous transplantation. And then I certainly agree with the second one when we're deciding whether or not a second autologous transplant is useful. Depends on how much benefit you got from the first one, right? Kind of makes sense, right? If you got something good out of the first one, then a second one will likely help. If not, that's when we'll think about maybe doing an allogeneic transplant in selected patients that are going to need that graft versus multiple myeloma effect, somebody's new cells to get in there. And the other question you asked was then, if you need a second transplant, how do you know you're going to get enough stem cells? Has your marrow burned out? And I think that was what you were asking earlier on. Because with all these therapies, some of them can bother the normal stem cells inside the bone marrow. And we give medications to try to get those stem cells to come out from the bone marrow. And over time, there have been new ones developed that work really well. And so your doctors would be able to watch you each day and see if enough stem cells are coming out into your bloodstream to see if they're going to be able to collect some. Okay.
Thank you.
You're welcome.
Very much, both of you. Thank you.
I just might have a small comment that many of us collect sufficient stem cells the first time for more than one transplant. They're in the freezer, and you should check with your team to see if you have those cells. If you have those cells, that's good to go. You don't need to worry about what's going on in your bone marrow right now as far as your normal hematopoietic cells.
Yep, it's a good point.
And I understand with myeloma, with the genetic changes that, constantly change. So the disease can get progressively worse.
Yep, that's pretty much true for all diseases with time. Yeah.
That's another factor. I appreciate all of you.
You're welcome. Other questions? Yeah.
I have a question for the Be the Match lady.
Yeah, that's me.
While I was hospitalized, every day in the morning, the teams would come by, and they're called the blue team, the white team, the red team, the purple team, which was the transplant team. Never stopped by, never met me. And after I got done with the first consolidation chemo, it was suggested to me that what they did have was a 4 out of 6 match with cord blood, and I asked why wasn't my daughter, my sister, or my son contacted for a possible transplant, and I got no answer. And so I got nervous, went to Mayo, talked to Mayo, then I went to Houston, you know who I saw down there, and the question is, if we would have went with the 4 out of 6 matches on cord blood, does that have a higher percentage or a lower percentage of survival than with the related/unrelated donor?
So I can provide you with some of that information. I was at the University of Minnesota for about 25 years, and John Wagner there really started a lot of the umbilical cord blood work, along with other doctors at Duke and other institutions. So we used a lot of umbilical cord blood, and I know Dr. Tsai as well. So for umbilical cord blood, that's one of the nice things about it. You don't have to have a perfect match. And they're also banked, okay? So that parents, out of goodness of their heart, donate the umbilical cord blood. So if you need to go to an unrelated transplant and you need to go quickly, you can typically give the patient's disease and the patient's healthy and ready to go to a transplant. We could get to a transplant in 1 or 2 weeks. Those cord bloods are just there, and you don't have to have a perfect match. So that really benefits people with different ethnic backgrounds, for which it's difficult to find an unrelated donor. Now, haplotransplant that we both talked about a little bit, where you just asked, what about my daughter? What about those are half matched. And that's relatively new, all right? We didn't have a really great way to make those transplants work. And that's why when you asked, people kind of looked at you, well, no, we need a match. But the outcomes are looking very, very good. And there is a study ongoing right now through the big transplant networks comparing umbilical cord with half-matched, okay? And we're about another year and a half away from completing that trial, and then there'll be some follow-up for results. But there's good pros and cons about either source. And so right in this day and age, a physician has to say, how fast do I need to get to transplant? Are there healthy half donors? Always would do it in the context of a clinical trial, because that's where we're going to learn the most. Anyone else want to speak to that? Or Dr. Tsai, did you want to say anything about that?
Yeah, no, I mean, I agree with what you said.
Right. I think I agree that, because as soon as you ask your question, what came to my mind is that haplo transplants are fairly new. And some groups had more experience, especially those who pioneered the studies. They probably would have taken that in consideration. But at the beginning, the notion was that it was going to be a mismatch, and transplant physicians were trying to stay away from mismatches, except on the cord blood field, in cord blood stem cell, that they felt comfortable with that approach. That said, the studies that are out there suggest that they might be safe, perhaps slightly safer than cord blood stem cell transplantation. On the other hand, in regard to long-term effectiveness, because we have more experience with cord blood stem cell transplantation, we all have patients who had transplants in the early 2000s. We're talking about more than 15 years ago, and no evidence of disease at this point, and we're talking about leukemias that were very aggressive, Philadelphia chromosome positive, relapse, AML. I mean, diseases that most people would have thought that there was no option. And after cord blood stem cells, you have long-term people cured from their diseases. So at this point in where this field is moving forward so quickly, I believe it is a matter of keep the discussion while you're doing exactly the right thing to do, coming to events like this one. Because the study have shown also that people like all of you do better. And again, that is another data that you don't have to be a doctor to know that if you're involved in your care, you continue looking for more information, your outcome is going to be better compared to the person who's more reliable on what they are being told. So congratulations to all of you, and keep your journey, keep your questions, and looking for the right answer.
So I have a comment about the protocol. First, and you can correct me if I'm wrong, but you were seen by your leukemia docs, but not the transplant team when you were in the hospital. As transplanters, if we start going into everybody's room uninvited, we would be thrown out either by the patient or the family or the doctor. What are you doing here, et cetera. So in retrospect, it makes sense why didn't the transplant team see you? And in fact, we do have data that of all the eligible patients nationally who are eligible for transplant, only about 20% of patients actually get to that point. And it's largely because we're not invited in. So we did a national study funded by the National Cancer Institute, in which everybody who signed, every center who signed up for the protocol had, as part of their initial evaluation, a evaluation of finding a donor and actually be the match, got the samples, and they searched. The centers didn't even have to search. It could be done at the Be the Match. And we found that not 20%, but 60% of patients on that study actually went to transplant. The therapy was not different. The chemotherapy, et cetera, it was a minor modification, but it wasn't better than the standard of care. So part of the reason that we have this conference is to emblazon you guys, or to empower you guys to say, wait a second, I just been on the website, Leukemia Research Foundation, Leukemia Lymphoma Society, and they say, I'm 55, I have AML, and I might need a transplant. Can I see the transplant team? Or where is the transplant team? But for us walking around the halls, we wouldn't be necessarily welcome, because some patients don't want to hear about it. They're offered and say, I'm not going to do that. I don't want that. or my cousin's sister, brother, niece had a transplant in 1970 and it was horrible, and it's on and on. We hear all that. So we're not going to go in and make your emotional life worse unless somebody basically preludes for us to come in. But we're happy to see any patient at any time. But again, we feel, based on the study that we did, because 60% of patients went on to transplant, we're missing 40% of patients. We're almost missing half of patients just in regular standard of care. We feel that everybody with acute leukemia should at least have somebody consider typing them to find a donor. We may never use the donor. We may never consider you for transplant, but it's available. What Linda mentioned as far as cord blood, we can get a cord blood in a very short period of time, but an unrelated living donor, that sometimes takes a couple to 3 months to get a donor. That's the extreme. But so if we knew that when you were in induction therapy, by the time you got to consolidation, even if it took 3 months, we would have a donor for you.
Yeah, just to follow up on that, I think my bias has always been for patients with acute leukemia to be treated at large academic facilities or facilities that have both leukemia doctors and transplant doctors. When a new patient walks in the door, we're already thinking, what's the next step? A lot of times these patients are getting the same type of treatment up front, but I know I plan 2-3 steps ahead. I have plan A, B, and C. And so we do want to involve those transplant physicians early. And so, again, my bias is to get these patients to large centers where the leukemia doctors and the transplant doctors can actually work together. Because if there's a delay in getting them to transplant, we're able to make those plans to continue the chemotherapy until transplant can be done.
And even, and I think that a very important point. You need both teams, and I can tell you that sometimes even within the same institution, both teams don't communicate effectively, and that's why your role, your important role, comes into place, because how many times I have heard, oh, I never sent that patient is too old for a transplant. And coming from someone who has never performed a transplant before, and the concept of transplantation was there based on the medicine that they learned 15 years ago. So they believe that the side effects that they saw 15 years ago are still happening. They are not aware of drugs that we are having now, supportive care that we have now. And I have heard this about the age of the patient based on 63 years old. I have been told, 63 years old, I'm going to transplant that patient. Said, of course I will, because we have transplanted 74 years old and they have done great. So it is always very important to be involved in in those options that are available for you. Transplant is scary for everybody because you have never thought that you were going to be discussing this option. And sometimes if you find a physician who tells you what you want to hear, so it's easier then to go from that route. But keep in mind that at the end of the day, if you look carefully, there's going to be patients who are going to survive and leave these malignancies behind. So again, I think that it is important to make sure that all your teams communicate, and you can request that.
I had a quick question about after an autologous transplant, how important is a maintenance program once you're finished with the transplant out of the hospital and all those things? How important is it? And also, are there situations in which you may not need a maintenance program? That's the first question. Second question, so
Do you have a particular disease?
you want to answer the first one first?
Do you have a particular disease?
I'm assuming you're talking about myeloma, right?
Myeloma.
Right. And the second question?
The second question had to do with a type of treatment. It's still in clinical trials. It's called CRISPR, number 9. You guys, I don't know if any of you are familiar with it. But if you are, I'd like a little information on it in terms of the progress that's being made with it so far. And if down the line they think that would be probably the type of treatment to use from then on, because it seemingly had a really good response with the patients, some of the patients that have been exposed to it.
Well, in regard to the maintenance therapy, that is still a topic of debate. More physicians are getting convinced that some sort of maintenance might be necessary for some patients. I can tell that there's no consensus, even in forums in whom only myeloma experts are discussing guidelines. I can tell you that for the most part, patients who present with a biological variant of multiple myeloma that is more aggressive and tends to recur quickly, those are the patients who physicians feel very comfortable offering maintenance therapy right away after stem cell or even after regular or standard therapy for those who achieve a complete remission or near complete remission, very good partial remissions, etc. In regard to this, what is the best maintenance therapy? That is also depend on what was effective during the induction therapy. It was an immunomodulatory drugs like lenalidomide, thalidomide, or thalidomide probably is not the best drug for maintenance therapy because of the toxicity profile, but pomalidomide, lenalidomide, bortezomib, some people are using now carfilzomib, some sort of maintenance might be indicated. That said, I don't know if you remember the slide that I showed about the guidelines for relapse myeloma. There were patients who are not on maintenance, and or they are too frail, and there are some recommendations for what to use when you're treating those patients. So across the nation, there's a group of patients who are not on maintenance therapy. But if you have cytogenetic abnormalities, for example, that makes likely that the relapse is going to be quickly, probably maintenance is going to be recommended. If we're talking about someone who was not on maintenance but relapsed, that patient also most likely will benefit from some sort of maintenance. So at this point, it's fairly individualized, the need or not need. In regard to clinical trials, very of them are very promising. I showed one of them that I believe has been discussed in several of the transplant meetings that I think it's going to be promising, but like Dr. Venugopal touched that point. We have very promising drugs, and we have established treatment that has shown benefit for now many years. And that's why we need to be careful when we choose those therapies, because we don't want to use a promise and switch that for a treatment that has been well established, and we know side effects and we know long-term survival. So yes, it's very encouraging. If we want to benefit from those drugs, probably we should do it under the clinical trial. Rather than off trial, and just make sure that your options that are well established are out of the question before going for a promise, because a promise is a promise.
Pat, did you want to talk about CRISPR? Go ahead.
No, you please.
Yeah, so there are a variety of approaches ongoing to try to change cancer cells and non-cancer cells by using techniques to change genes. And so these are all in clinical trials, but very promising. And I guess that's probably the simplest way to mention it.
CRISPR.
Yep.
Anyone else want to comment on that? I don't know if anybody else knows anything.
So the comments that you want is about if someone should participate on the trial or
No, about CRISPR.
how close we are for FDA approval.
For gene editing.
I think it's a ways
We're
away.
ways.
Right,
We're ways.
it's not something that is on the near horizon. So that's what I mean. For someone to enjoy the potential benefit, should be under a sponsored trial. Yeah.
Hi, this question is for Dr. Stith. Could you talk a little bit more about the immune cell therapy approach to relapse lymphoma patients, and specifically, my wife went through, as you know, an autologous transplant after a difficult chemotherapy regimen, and we're coming up on 2 years out of the transplant this fall. We understand that relapse likelihood diminishes over time. In the sample you have so far on the lymphoma patients that have gone through immune cell therapy, is there a correlation between the time the duration after the transplant and the relapse and the success of the immune cell therapy?
So that's a good question, and the answer does not appear to be. Most patients who've gone on these trials are patients with pretty bad disease. It relapses pretty quickly, usually within 6 months after the auto transplant, or it's people that have failed to get to the point where they could even have a transplant. The disease never responds. And the current status is, again, it's been submitted to the FDA for approval. The FDA is in the process of doing an evaluation themselves. Once you submit your final documents, the FDA then does it's a review of the documents, actually visits several of the sites where the trial was done and reviews the records and individual patients there, and then they come back, do a report, and then it's presented at a meeting at the FDA with advisors from the cancer community, and then they give their advice, and then the FDA ultimately then decides whether they're going to take that advice or want additional studies. The important things here to remember are A, it's effective, but B, it's pretty toxic at this point in time. I think the learning curve for the toxicity, just like transplant, is there. It's going to happen, and there are already things that we may be able to do to reduce the risks of toxicity. And I think ultimately what will happen when we do this in real patients in our centers is that we won't let them get so far advanced to the point where they're really in extremis, and some of these patients have been. We'll do it a little bit earlier. We have a patient right now who's failed 2 lines of chemotherapy, and we're giving him radiation therapy. In lieu of the radiation, he would have been a great candidate for that. It's not available currently. But those are types of patients, rather than waiting till he fails a transplant or fails the radiation and he's far more weak, et cetera, and has more complications. So very promising, and I think the toxicity will go down, the effectiveness may actually go up.
Hi, I want to thank the panel for being here. I'm a CLL patient, was diagnosed in 2000. In 2006, I went through my first therapy with FCR, was very successful, in remission until 2014 when I did the Triana plus Arzera. That was a very difficult therapy, but I came through it and consequently went on the Arzera maintenance program for 2 years. I could only tolerate it for 1 year because my neutrophils were failing pretty consistently. And from May of 2015 till about April, just about 6 weeks ago, I had about 15 Neupogen shots to keep me going on the neutrophils. And but I'm still in remission. My leukemia cells have remained pretty dormant during this period, which I'm thankful for. I've got 2 prognostic indicators that are poor 11q deletion and unmutated. I have 2 questions. The first is, the next round, the drugs I've used are pretty much off the table. What are the pros and cons of the best next thing that might be available? I understand ibrutinib, Gazyva, and venetoclax might be possibilities or some combination thereof. My second question has to do with the CAR-T regimen for CLL patients. I noticed that was not on the approval list that Dr. Stiff had, but I want to know what the status of. I'd been following the Pennsylvania studies, and I just had a program on National Geographic this week about that program. It kind of left you hanging at the end, but it was very interesting to see. But I'd like to know what the status of the FDA approval is for that. And secondly, the toxicity that Dr. Stiff mentioned related to these, are they more to do with the condition the person was in before they started it, or are there other factors that lead to the adverse effects?
So Vino, you want to talk about the CLL?
I think he has been hearing from me, including this morning, what my recommendations are, but for the sake of others, I will just repeat some of the things you mentioned. I mean, he's mainly asking the question to get input from you all. So if you remember the talk I gave, I think the story you have is the story you just told about CLL, the FCR treatment, which was one of the chemotherapy regimens we talked about, and subsequently you got one of the monoclonal antibodies, Arzera, which is of a tumomab. And now it looks like you have low white blood cell count, right? I mean, that's what you mentioned. You have received Neupogen shots to increase your white cells. So the low white cell count is not something we see in CLL. Usually it's the other way, right? In CLL, the white cell count is high. So your low white cell count is most likely because of the results of the treatment, the late effects of treatment, like FCR has a drug called, one of the drug is fludarabine, which sometimes can cause suppression of the bone marrow, causing low white cell count for a long time. So that brings back to some of the discussions you had earlier in response to some of the questions. For example, you need to be aware of a sequencing of therapy. In other words, in diseases where you know that you have to be planning for treatment for a long time and you have several options, you need to know how to sequence the treatment, because some of the treatments, if you choose in the beginning, can compromise your options for future treatment. Like, radioimmunotherapy is a treatment. Sometimes when patients receive radioimmunotherapy in the beginning, they may have difficulty in harvesting stem cells or even development of myelodysplasia that may cause problems with autologous transplant eligibility. So I think the point is the low white cell count could be from the treatment you received. The best way to find that out, of course, is to do a bone marrow biopsy, because that will show the changes related to the previous chemotherapy, or it may be that your CLL is filling the bone marrow, causing low white cell count. So those are the two possibilities. Coming back to the question, what are the future options? And you already said ibrutinib, which I showed you, is certainly likely to be a very good option for you, because you indicated among your prognostic factors you have an unmutated IGVH gene, which, if you remember, I showed that ibrutinib response for the mutated and unmutated are very similar. At least the data we know for the first 4 or 5 years, the data is very similar. So that would be a very good option for you. Ibrutinib, the concern, of course, is you have to take it continuously. You don't just take a course and stop it. And there are some side effects which are not as bad as some of the side effects of the chemotherapy you got. But one of the concerns would be if you are on any blood thinners, that could be a problem, because ibrutinib can sometimes increase the risk of bleeding. It's not a contraindication, but those are things that you have to be careful in selecting the next treatment. Any others would like to comment?
So I agree. I think you should have a thorough evaluation of your bone marrow and what's going on in your bone marrow, and you do that by doing a chromosomal and a FISH analysis to not for your CLL, just for your CLL, but also for your normal hematopoietic stem cells. And FCR is a combination that does produce significant bone marrow damage in about 7% of patients. So I think that's something that you need to take into consideration. There's another drug called Revlimid, which also may be of value. It's a little bit less toxic at a lower dose and may be of value. Regarding the CAR Ts, I think the two signals are that the two companies that are approaching the FDA for approval, one is for the lymphoma patient population. And again, what the companies like to do is a low-hanging fruit in which there is no good option for patients. So non-Hodgkin's lymphoma, large cell lymphoma that have relapsed, we don't have anything for those patients. We're continually working on some new drugs, but those patients never go into complete remission, or if they do, it's gone within a couple months. So that's something that the FDA says, wow, people die, or you have a therapy that might produce long remissions in about a third of the patients. Well, that catches their attention, and they're more likely to kind of not look the other way, but acknowledge the fact that there is toxicities, but the toxicities are built into that 30% or 33% For CLL, and again, I'm speaking as myself, and why aren't the companies doing that? It's an older age population. There is a toxicity associated with it, and there are lots of good alternatives to patients nowadays. There's ibrutinib. There's now ibrutinib congeners that people are testing, venetoclax combinations with antibodies, et cetera, and these are keeping patients alive many, many years, so that it may never be needed, except in rare instances. And if your bone marrow has been damaged by your prior therapy, it's not CLL, but you're getting a myelodysplastic syndrome, then that's something that requires a shift in your therapy and a shift in your approach. And we occasionally do transplant patients with CLL in remission that have bone marrow damage from the FCR combination. So that's kind of where we are right now. And you asked about the toxicity. It doesn't appear to be age-related or disease-related. Thinking about this, and there's some preliminary signals as to who might get it and how it might develop, and a lot of these are covered in what we call confidentiality agreements that we have when we do these trials. There's going to be a presentation at ASCO. I think there'll be a publication of some of the data on that. So, but I think we have some clues as to not only what's happening, but maybe how to ameliorate that. But again, we're talking a patient here and there, and there's just so little data that I should not really go further.
And just to reiterate, I mean, if you need a treatment, that clinical trial I mentioned, you are very likely to be eligible for that, because that also is an important point, that is sequencing of therapy, because there are other drugs also in the market which you would be eligible, like idelalisib or Zydalig is a drug which may be appropriate for you, but if you take that, then you won't be able to get into the clinical trial because you will be excluded. So I think the point of sequencing of therapy is very important. I'll hold it.
Hi. So my mom has been receiving treatments for myeloma for the past six years. Never done stem cell transplants or anything like that. Mostly different kinds of chemotherapy and radiation. We were wondering what the instances of myeloma spreading to soft tissue, how often that's happening. Her current oncologist is baffled, I guess, from the amount of soft tissue that the myeloma is reaching. She currently has several tumors on her skull, but it's in the scalp, not necessarily on the bone. We've been told that there's tumors now on the liver, parts of something about the pancreas and other different parts of the stomach. So we're just trying to understand if myeloma is it normal for it to go to the soft tissues? Because I've heard of several instances of just one or two things, but it seems to be spreading everywhere. And then the other question that I had was, her doctor seems to focus mostly on the proteins, the M protein, capitalite chain, and all those different things. Now, with the chemotherapy, the thalidomide, all those things like that, these numbers keep going up, drop for a couple of weeks, and then go right back up. She was able to achieve remission without stem cell therapy, but that lasted for about a month. So I'm just trying to find out what the normal course of action is, and now with this new soft tissue spreading, what are we looking at?
Well, you see myeloma going into soft tissues actually as a result of the success that we have with some of these therapies. When, as I was saying on my presentation, when the survival of patients with multiple myeloma was short, it was really rare to see involvement of soft tissues, because unfortunately there was no time for that to happen. With the new therapies coming up and having patients living longer and longer, now we start seeing myelomas where we were not seeing myelomas before. And that includes soft tissues, the blood transformation into a plasma cell leukemia. We're seeing that more often now. So in regard to that tell us that the approach with this patient needs to be more intense and more aggressive. In regard to following the protein, it's because some doctors have been caught on this methodology that we were using when we were not seeing the myeloma. Everything was microscopic. In order to avoid those bone marrow biopsies on every visit, you were following the monoclonal protein. But now by definition, we have that any protein that progresses or comes back within 60 days of the therapy is considered refractory. So yes, sometimes we feel encouraged because there's a drop, but as you mentioned, it's transient. And then we need to modulate the therapy, increase the dose or add something. So you know that you are confronting a condition, a disease that is progressing. So there's many things in consideration when you try to switch a therapy. It's not only about the myeloma. The doctor is going to be taking in consideration the renal function, for example, the performance, other organ toxicities, prior therapies, neuropathy. There's many factors in that formula at the end in order to come up with a treatment plan. I can tell you that just in general terms, based on what you're saying without knowing details, because as I mentioned, I brought up renal function, and renal function is not only creatinine. So a person in that situation might need a more intensive therapy. And combination of drugs, and perhaps that stem cell therapy that was not given is something that should be considered at this point. And that will be one of the few cases in where that tandem autologous transplant might have a role. And in some individuals, depending on age and organ function, the allogeneic stem cell therapy might have a role. And certainly, clinical trials and immunotherapy has some relevance in those kind of situations.
Yes, I have non-Hodgkin's lymphoma. I had a stem cell transplant about 4 years ago. But then I relapsed about 10 months after the transplant. Did I understand you to say there was a drug that a person can take to prevent relapse? Or was it not available at that time?
To prevent, like a maintenance, you mean? Are you aware of any maintenance for?
No, not for diffuse large cell lymphoma. Does anyone else want to comment? I mean, studies have been done looking at maintenance therapy and a variety of non-Hodgkin's lymphoma, but hasn't really been shown to be effective, particularly for diffuse large B-cell lymphoma. About half of patients who undergo a transplant for lymphoma will relapse. So that's one of the biggest problems with that. Autologous transplantation is simpler because you're using your own cells, but that is where Dr. Stiff was talking about the CAR T cells that are looking so promising for diffuse large B-cell lymphoma, the B-cell lymphomas that are in clinical trials right now. It's also a situation where historically, that when patients had the disease come back so quickly after an autologous transplant, that we would think about attempting to put their disease back into remission and then going to an allogeneic transplant using someone else's cells, hoping that someone else's cells after a transplant would be able to help keep the cancer away. It was called a graft versus lymphoma or graft versus tumor effect.
Mm-hmm. So yes, I think that in a situation like that one, immunotherapy in all its forms is probably the way to go. Loyola, in fact, there was an analysis of patients who went for allotransplant after, quote unquote, failing or relapsing after an autologous transplant. And actually the outcomes, I'm sure that Dr. Stiff will be able to comment further about this, but the outcomes were better than we were even expecting. That was a presentation at the American Society of Hematology. And what I'm saying is that any sort of immunotherapy, because CAR T cells actually is a more sophisticated, selective type of immunotherapy. But allogeneic stem cell transplantation is more rudimentary. I will compare that like taking a cup of tea that you boil the leaf and the roots and the medicine is there versus selecting the medicine. and be more pure. And I think that the best chances is to pursue that immunotherapy, but I'm sure that you.
And then I just wanted to mention also that now I think we have the ability to profile large cell lymphomas a little bit better and tailor therapy in that direction also, using markers like BCL2, BCL6, and MYC. We're putting them in categories like double hit, triple hit, and potentially accelerating treatment before the transplant, transplanting in remission versus at relapse.
So let me comment. There are a couple lymphomas that we use maintenance therapy in. One of them is mantle cell lymphoma, and there's some data both in elderly patients without transplant and then younger patients with transplant. So now, if you have a transplant for mantle cell lymphoma, we do give rituximab maintenance for a couple years. The second is Hodgkin's disease. We kind of mentioned it already. There's a drug called Adceris or brentuximab, which is an anti-CD30 monoclonal antibody, and that was given in a randomized phase 3 trial with half the patients getting drug, half the patients getting placebo, and we showed that remissions were significantly longer, even up to 5 years now. Patients with Hodgkin's disease do so well, we need a little bit more time to determine if that's going to translate into survival advantage. As was mentioned, there are three major genetic profiles for large cell lymphoma. There's the activated B cell type, the germinal center type, and then there's the mediastinal large cell type. We're in the process of doing a maintenance trial in this country now after auto transplant. It's a placebo-controlled trial for the ABC subtype, which is about half the patients with large cell lymphoma. And for that study, ibrutinib is being tested as a maintenance therapy because ibrutinib is effective in about 40% of patients with large cell. For the more common or the GCB subtype, there's no real targeted agent available at this time, but there's one inching its way towards the possibility of doing it. And actually, I just sent an email to the company telling them I wanted to do a study with their drug, which is not commercially available. It's not even available for trial in large numbers of patients, but it is probably the cat's meow for this subtype. And then the mediastinal large cell lymphoma, there's some data that Revlimid or lenalidomide may be of value and could be used in a maintenance fashion, but again, no data for that. So if it's a typical large cell lymphoma, then no maintenance. We did try rituximab, doesn't work. You just watch patients and then try them on whatever else therapy. But what subtype you have would dictate what we would do next.
Well, I'm now taking Gazyva because I became Rituxan resistant. But would CAR T cell therapy be more effective than the Gazyva?
Theoretically, yes, because it can produce long-term remissions. So what happens when you submit something to the FDA, there's a quiet period in which if you do more trials or if you do more patients and there's toxicity, then that's got to be put into the mix, and that slows everything down. So generally, they don't want to you've done your studies, you submit it, you wait for yes or no from the FDA, and then you start releasing it again to the public. So it's not available, at least from the major company that's doing those trials right now. But down the line, potentially in about 6 months, we hope.
We have time for one more question. Two more questions, one here, one there.
First of all, thank you. It's really been incredibly informative. And when you sit here as a patient, you kind of say, oh, that's not my issue. And then along comes your issue, and you go, okay, I need to really listen. So here's my point, having said all that. I did MUGs for 5 years, and then I did 6.5 years multiple myeloma, stable for 4 years. I've spoken to Dr. Burns. We omitted the fact that I could now go into possible transplant at this point, but we'll proceed that. In 201, I had thyroid cancer. 204, I had ovarian. 208, I had ovarian and breast again. So I've been busy. So I don't have enough of my own cells, but my question is, if you were stable for 6.5 years and I was your patient with a good heart, everything else in this machine is running well, would you change your course?
No, I mean...
Revlimid, Dex, and...
Velcade. That's what you got. And at this point, your disease seems to be, the myeloma part is supposed to be in remission, stable.
Yes.
Right. No. So I will continue with the course at this point, and I will not move forward into anything else unless I see any signs of progression, even if it's asymptomatic progression. If I see a chemical progression, then I will consider. But at this point, you're doing well. I will not do something different.
Thank you. I also have one more comment. I spoke to Dr. Tsai, is that how you say it, in the ladies' room, and we exchanged this information. These printouts are fantastic, but everybody who does a printout, when you print it out, it is so small, the PowerPoint, that if I was to want to share it with one of my MM friends or my leukemia friends, it's barely legible when you print it. Is there any way that you could print it so that square is larger or more visible? Oh, sorry.
That's actually us. We prepare those for everybody so they have it in their packet. You can increase it on a copy machine. We do have them at the office. You can check with us. We'll be happy to email it to you, and it's far more pliable. You can work on it anyway. And as I said when we started, all of this is going to be available on our website, which will be much more legible than what you have in your packet. So there's, if you want any of this information, we can give you the pure PowerPoint by just contacting the office.
That she might have.
Probably within a week, 10 days.
Genetic syndrome that she might have with all these cancers.
Yeah. So also just speaking to a little bit about profiling of diseases, looking for familial cancer syndromes. You know, when a young person has several malignancies, we tend to do testing, germline mutation testing, and I wonder if anybody's spoken to you about testing for germline mutations, which are mutations that are present. Some patients are born with mutations that increase their risk of malignancies in different sites.
Because you mentioned that you had different type of malignancies, that breast cancer, ovarian cancer.
And the ovarian.
Okay, it's my loss. I have a lot of hearing loss from all the chemo, and you said what at the very last point?
That testing for germline mutations, which is mutations that you are born with that increase your risk of developing cancers like P53, BRCA. There's syndromes where cancers occur in the same patient, multiple malignancies back to back. Has anybody spoken to you about being tested, seeing a genetics counselor?
Have you been tested?
Okay, thank you.
Okay.
It's important not just for you, but for any of your children that you might have had. So that's very important. So you might have a genetic familial cancer syndrome. Most people aren't unlucky like you and get. Okay, so. But they should check for other things as well, not just because a lot of times they'll say, "Oh, you have breast cancer, so we'll do a BRCA2." You may have something else that also needs to be considered. So you should definitely see a genetics counselor.
My son's dog has lymphoma. Do you ever work with vets or dogs?
So, can you raise your hand? Who is this? So, it's interesting. Somebody was in the clinic the other day, and they said that they had a dog who had lymphoma, and they were on a clinical trial at University of Wisconsin Veterinary School. So there you go. That's a tip for you.
So I actually have as well.
We don't. Loyola did a few years ago before Brookfield Zoo had CAT scans. We brought over some large animals and did in the middle of the night CAT scans and MRI scans, etc. But now I hear they have their own CAT scanner to help diagnose disease, etc. So
they let dogs in the CAT scanners.
Well,
only one at a time.
They put it this way. I have a friend who took one dog in the middle of the night for a CAT scan. So
I was going to mention that the University of Minnesota, we have a very close working relationship between the lymphoma experts and the veterinarian. So it turns out that there are pathways of how lymphoma can form that are very, very similar in dogs and in humans and may lead to some new targeted therapies. So we've published that data this past year. So there are some similarities, but not many, but dog is a good model for lymphoma.
And I hear they lose their hair.
Okay, ladies and gentlemen, please join me in a round of applause, thanking the doctors once again.